Thank you for joining us today. The first question is about the FAME trial. Recently, FAME 2 study was halted the enrollment after only 2/3 of planned patients were included. So, would you tell us how can we interpret this result?
Yes, so the FAME 2 study is a multi-center international study looking at comparing FFR guided PCI to optimal medical therapy in patients with stable multivessel or single vessel coronary disease. And the idea behind FAME 2 was to, in a sense, redo the COURAGE trial. COURAGE taught us that angiographic guided PCI compared to optimal medical therapy in patients with stable coronary disease resulted in similar rates of death and MI. One of the concerns about COURAGE was that some of the patients enrolled may have been low risk and not had significant ischemia, and we know that stenting in patients without significant ischemia is unlikely to have any benefit. In addition, there may have been stents placed that were unnecessary because although the angiogram looked like a tight narrowing was there, it was not functionally significant, and using FFR might improve that. So in FAME 2, in order to be included in the primary part of the study, a patient had to have a significant stenosis on the angiogram, but also have an FFR less than 0.80. And if they did fulfill those criteria, then the patients were randomized to either PCI plus optimal medical therapy or optimal medical therapy alone. The idea here again was to enrich the study population with patients who truly had significant ischemia. And our goal was to enroll 1,600 patients, and after about 1,000 patients were included, the Data Safety Monitoring Board strongly recommended that we stop the study. The primary endpoint of the study was to be the rate of death, MI, and hospitalization requiring urgent revascularization, that composite at 2-year follow-up. But what they had seen was that in the OMT arm, the rate of hospitalization and urgent revascularization was significantly higher than it was in the patients who had FFR-guided PCI plus OMT. And because of that, they thought that ethically it wasn't reasonable to continue with the study. We still don't know about the rates of death and MI, and we're waiting for all of the data to come in and to be analyzed, and hopefully we'll be able to present those results later this year.
What do you think the clinical implication until now with the result?
Yeah, so I think what this shows us is that patients who truly do have significant ischemia, there is a hazard to treating just with medication alone up front, and that using FFR-guided PCI will improve the patient's outcomes. So, these are still preliminary data. We need to finish the analysis, but that's the suggestion that these patients do in fact benefit from PCI. So in that sense, it's a different message than what we saw from COURAGE.
And what do you expect the result of ischemia study?
Yeah. So the ischemia study is a very interesting study that, to my knowledge, isn't underway yet, but funded by the NIH. That's going to include roughly 8,000 patients, is my understanding. And in ischemia, the decision is being made further upstream. So patients have a nuclear scan that shows a significant amount of ischemia, and then they're randomized to either a revascularization strategy, which would involve angiography, plus minus stenting or bypass, versus a medical therapy arm up front. And my guess is that if they truly include high-risk patients, that it'll show a benefit to early revascularization. Now, hopefully, they will include FFR in the angiographic patients, because if they just rely on the angiogram alone to guide the decision for revascularization, we know from FAME 1 that there are higher death and MI rates compared to incorporating FFR-guided PCI. So I think that'll be an important component as well.
From the FAME trial, the routine practice pattern changed to FFR-guided PCI. So actually, we have many interested about the functional score with FFR. So would you explain about the functional syntax score?
Sure. The functional syntax score is an attempt to refine the classic syntax score. The classic syntax score is an angiography-based scoring system to define high risk from low risk patients with multivessel disease based on the number of lesions, the complexity, the amount of calcification and tortuosity, and so forth. What we hypothesized was that if you calculated a so-called functional syntax score, whereby you would only calculate lesions that were functionally significant in your score, that you would be able to identify lower risk patients amongst those subset of what appeared to be higher risk group. And so we looked at the FAME data and the 500 or so patients in FAME 1 that were randomized to FFR guidance, and we first calculated the classic syntax score. And then after incorporating the FFR information, we subtracted any lesion that was not significant based on FFR and recalculated a functional syntax score. And we found that about a third of the patients moved from a higher risk classic syntax score to a lower functional syntax score. And it turned out that the functional syntax score was also a better predictor of outcomes, death and MI, as well as revascularization. So it's a way, I think, of identifying or redistributing patients from a higher risk group to a lower risk group. And it may have implications clinically in that some of these patients that we might send to bypass because they have what looks like severe 3-vessel disease actually only have 2 or 1 vessel disease, and we can treat with PCI.
You have a lecture about the role of FFR in unstable angina and non-STEM in this conference. Yeah. In real practice, actually, it's not easy to measure FFR for ACS patients. Would you tell us what is the role and benefit of FFR in the unstable angina or non-STEMI patients?
Yeah. In FAME 1, again, this was a multi-center randomized study looking at patients with multivessel disease. About a third of those patients had unstable angina or non-STEMI, and they were randomized to either angiographic guided PCI, where the operator decided which lesions to stent based on the angiogram, or FFR guided. And among the 300 or so patients that fell into that category, we looked at the benefit of FFR guidance, and it was still better as far as decreased rates of the composite endpoint, death, MI, or need for repeat revascularization, compared to angiographic guidance in that group. So I think if you have an ACS patient, FFR is still very helpful. Now, having said that, from a clinical perspective, I think more often than not, it's obvious based on the angiogram which lesion is the culprit. Usually EKG gives us some help also, and you have a lesion that looks maybe hazy or thrombotic, and so you don't really need FFR, in my opinion, that much in the culprit vessel. It's more for the non-culprit, and many of these patients have 50-70% narrowings in other vessels, and using FFR in that setting can be quite helpful.